Hello everyone, and welcome to this workshop. This is to be our first of 4 horizon scanning workshops organised by the Nuffield Council on Bioethics. I'm hoping that you're all aware of who the Nuffield Council on Bioethics are, but just in case you aren't, we've been around for nearly 30 years. We are, I suppose, the closest that the UK has to a national bioethics committee. I'm Sean Pattinson. I'm currently Deputy Chair of the Nuffield Council, and I'm also Chair of the Horizon Scanning Group. Now, the purpose of Horizon Scanning, as that title suggests, is to seek to identify current and upcoming developments in our area. Now, today's topic is the role of bioethics in COVID-19, policymaking and pandemic preparedness. The Nuffield Council has argued throughout this pandemic that the issues that arise are not purely scientific and require discussion of further, particularly ethical issues. Now, today's workshop is going to start with 4 very brief presentations, after which we are going to we're going to have a very short discussion among the speakers, and then we're going to go into breakout groups. When we're in breakout groups, there's going to be 3 of them. That will be everyone's opportunity to participate. So for this first session, the only people who are going to be able to speak will be the speakers. Now, because the time is short, I'd like to move immediately on to our first speaker. Our first speaker, Professor Bobbie Farsides, is Professor of Clinical and Biomedical Ethics at Brighton and Sussex Medical School. She is going to speak to us today about transparency and trust. Please,
Thank
Bobbie.
you very much, Sean. Well, I'll try very hard to stick to my 5 minutes, but it might mean I'm a bit speedy. Well, I'm not going to try and tell such an august gathering anything they don't know already. Rather, I want to offer quite a personal reflection on bioethics' role in this pandemic and preparedness more generally, a subject I've been thinking a lot about in recent times because of mine and Annika Lucason's Wellcome Trust project, which is about ethical preparedness and genomic medicine. But in this, in relation to COVID, I'd like to concentrate rather on how bioethics can help to contribute to or even correct flaws that have emerged around transparency and openness. Because as bioethicists, we're very used to showing our working out. And in the last 2 decades, we've increasingly backed our arguments, our philosophical arguments, with reference to empirical data. Many of us have been involved in policy making for a long time, and various emergencies have come and gone, but nothing has been quite like this. So part of our role must surely rest with being clear about the importance of values when planning for and responding to a national emergency. Articulating clearly the standards we aspire to and those below which we should not fall. We need to help people to understand how and why it is wrong when these ethical standards are breached. And we need to attempt to explain that being led by science or the markets does not occur in a moral vacuum. But to do these things, we need a platform at either national or international level. We need publicity and we need people being willing to listen to us. I fear few of these have been available to the majority of bioethicists, save through the exceptional efforts of the Nuffield. Specially formed ethics committees have operated in the shadows, and small numbers of individuals have been invited into the control room. But if I'm honest, in a time when we're all meant to be pulling together to, quotes, protect the NHS or whatever slogan is current, it has been suggested at high level that it is impolite or even dangerous to criticise. It feels a bit like the early days of ethicists dipping their toe in research, and where research ethics was seen as problematic and ethicists seen as a barrier to progress. Yet at the same time, if we don't work hard on showing the working out, people will, I fear, remain and become increasingly more alienated. I'm personally very angry about the way in which the response to this pandemic has been undermined by poor political practice, how politics has been reduced at times to staged White House-style briefings, the blatant cronyism I see in relation to appointments and contracting that is only being challenged in the courts because of organisations such as the Good Law Project. I'm scared of the extent to which populism and anti-expertise sentiments have been courted in the interests of obtaining votes. I've seen only too clearly the co-opting of ethics to legitimise a system in which the ethicist is rendered increasingly powerless. In response to this, the ethicist is charged with finding the spaces where they can retain their independence and contribute to attempts to challenge constructively and lobby for change. Again, I commend the Nuffield and, from my own experience, the Biomedical Ethics Committee for creating such spaces. Whilst there is so much to criticise, what we want to be doing is getting to the nub of what matters to people, finding a common purpose and holding politicians to account against the standards that sets. Advocating for the vulnerable and highlighting the forms of discrimination revealed and heightened by recent events, be that the elderly, members of discriminated against communities, or those in countries who don't have the infrastructure of wealth we have been able to rely on. Reminding those in power that they cannot simply ditch issues of fairness and justice because it becomes operationally challenging, politically embarrassing, or simply too expensive, and working together to find ways of committing to these values going forward. I also think the bioethicist has a very important role in supporting our social science colleagues and giving the stage to them as appropriate. Whilst it is always better to understand the ethical issues, it is absolutely vital, I think, to understand the social science. What we say needs to be informed not just by what we think people ought to do, but what the social science tell us can is most likely to happen. We need to work with our scientific colleagues to ensure that they understand the complex responsibilities involved in leading the way. And we need to give voice to those who are voiceless. And in this, I include not just the vulnerable, but also, for example, civil servants, particularly public health colleagues, who have been more thrown to the lions more than once in this time and do not have the right to defend their position. Contributing to the continuance of everyday life, I think, is also a very important role for bioethicists. And I fear that some of the most valuable work that I have done in these last months is to carry on with projects that had already been started and which don't directly relate to COVID, but have inevitably been impacted by it. And we must already now, in terms of preparedness, cast our eye to the future and think how best bioethics can help to deal with the aftermath of this pandemic in areas such as palliative care, chronic care, and austerity. We need to prepare for the next immediate challenge, and I would say that that is vaccination. We can all applaud and be delighted that the science has offered us an opportunity to proceed in this direction, but we need to understand the challenges and be nuanced and subtle in our responses. So I'll finish by saying, for me, a response to COVID is not all about seeking the spotlight. We can do so much good on our own doorsteps, in our own communities. And for now, I'm very pleased to be staying local most of the time. There is such need out there for clarity and assistance. But when we are in the spotlight, we can help, hopefully, to rebuild trust by being open and transparent, showing our working out, and encouraging our political leaders to do the same. Thank you.
Thank you very much. We're going to have a discussion at the end, so I'd like to move on to our second speaker, who is Dr. Halima Begum, who's director of the Runnymede Trust, and will talk to us today about the impact of COVID-19 on Black, Asian and minority ethnic BME communities. Please.
Hi, thank you, Sean. Really great to be with the Nuffield Foundation in this incredibly important debate around transparency and openness and the role of ethics and science. And as Bobbie was saying, it has to be a collaborative dialogue as we all think about preparedness, though it's quite late still, and really appreciate the platform here. For those of you who don't know the Runnymede Trust, again, we've been around since 1968, and 68 was the year that Martin Luther King got assassinated in the US. 1968 was also the year in which Enoch Powell, very famous health parliamentarian at the time, made his Rivers of Blood speech. And we were set up by our founders and our foremothers and fathers really to put an end and say enough is enough. And I say this with a bit of emotion because we are sitting here in 2020 and we know all that has happened. So back to COVID. I'm just going to start with the personal as well, Bobbie. I was actually in Denmark when the pandemic broke, and I witnessed how the Danish government actually handled the pandemic. And it's really interesting to see how that was handled and to refer to other countries. And whenever you come back to the UK and refer to other countries and their response, our response always tends to be, well, that country is different because they've got a different culture, or they're more used to surveillance and so on. Obviously, in my book, South Korea is the best model. But whenever you talk to South Korea, whenever you talk about South Korea, it's easy to dismiss. But Denmark, which is culturally closer to us, seems to have managed it quite well. So that is on my mind when I refer to how we responded in the UK. There's something very specific about the way in which the UK has dealt with the impact of COVID on Black, minority and ethnic groups. I think everybody knows the numbers here. Everybody knows what the numbers were and the double, sometimes triple impact on BME communities. Well, despite knowing this since March, our government really hasn't prioritized BME groups as a vulnerable group, either for testing, tracking and tracing or for vaccination. Now, this is quite significant if we talk about the ethics of a response and we're looking at which groups to protect, yet we know what the evidence is telling us. Because if you were in France or Germany, the answer would be, well, we can't really do disaggregated policy making because we can't collect data on gender or ethnicity. In France, everybody's French first, so there is no ability to collect data on vulnerability. But in the UK, I've got to say, our public policy making is at its best. We do collect data that tells us who is vulnerable and who isn't. So despite that, despite knowing what we know, our government has actually applied a colourblind policy when it comes to protecting those groups that are most vulnerable. And it has not really moved far enough to protect vulnerable BME groups. You know the reasons why BME groups are exposed. Most of those reasons are external, to do with inequalities. And I say this with a lot of force here, because at the beginning of the pandemic, there was lots of discussions around genetics, underlying health conditions, but fundamentally the reasons for our overexposure is environmental. And we've carried out research looking into that risk and vulnerability with the Institute of Public Policy Research. You've got Dr. Parth Patel in this workshop who'll be able to talk a little bit more about that. And we're constantly saying that although socioeconomic inequalities are a factor in the risk of and the vulnerability of BME groups, you cannot dismiss ethnicity, because groups that are discriminated against suffer different levels of access and treatment when it comes to health and whether it's COVID treatment. We refer to that as racism and discrimination, and our government refuses to acknowledge that racism and structural racism can be a factor in relation to this vulnerability. And it's really important that the science community gets behind us. A few weeks ago, you will have heard that the science community was kind of divided somewhere in Oxford about who was more vulnerable to COVID. Was it elderly groups? Was it BME groups? And they couldn't really decide. But when the science groups can't decide, it gives government the chance to delay, and we know that every day counts. So we're not in the business of learning lessons about something that already happened. We're in the business of learning lessons so that we can save lives now. So that's really important to us, that when we talk about ethics, we do discuss this question as to why we haven't prioritized those groups that are most vulnerable. And it also begs the question, in a majority white nation like the UK and also America, the vulnerability of groups who have a different color skin, is that recognized? Is that visible? Is that understood? Or is there something about the way in which, is it incompetency on the government side? We don't know, but there is something very specific about the UK and the US response to COVID in relation to the vulnerable BME groups that doesn't appear to be relevant in South Korea or Singapore. And I say South Korea and Singapore because these are ethnically homogenous countries. So their ability to prioritize the vulnerable doesn't come with a feeling of, dealing with an excluded group who has always been made to feel as though they don't belong, for example. So that's really important. And I suppose the other thought that I wanted to leave here is that general one around transparency, openness, not feeling as though, you know, a constructive challenge is critical, because actually that constructive challenge might actually save a life. And I think we all have to be more democratic in our place in society, and not criticizing the government somehow feels as though we're not on the same side. I think we're all on the same side, but government needs to listen better. And to that note, the Runnymede Trust is also one of the co-claimants on the legal challenge taking Dido Harding and others to court. I personally am myself, actually, my name's on the court documents. It was a really important decision for us to take with a Good Law project, because on the one hand, the hiring of people without the right qualifications, really these people should have science and medical backgrounds, you would argue, people who are represented here, for example. But more importantly, there was a case to be made for indirect discrimination against the Equalities Act of 2010, both for people that do not look like the social set of our Prime Minister, but also people that might have disabilities, or people with disabilities. So we thought that there was actually a double charge there around indirect discrimination. I also felt it was important for the Runnymede to join that challenge, because we know that this pandemic is affecting BME groups disproportionately. So what does that mean? We've put some people in charge who not only are they underqualified for the role, but it actually puts in jeopardy the recovery of population from COVID, and particularly BME groups that are impacted most. So there were lots of reasons for us to join this. And I suppose it's about bringing better ethics, better transparency to our preparedness response. So I'll stop here now, Sean, and wait for some discussion about this afterwards.
Thank you very much. I'm going to move quickly on to our third speaker, Dr. Silvia Camporesi, who is Senior Lecturer in Bioethics and Society in the Department of Global Health and Social Medicine at King's College London. Silvia is going to talk about the role of expert knowledge. Please.
Thank you, Sean. It's a pleasure to be here. So in these brief remarks, I'm going to talk about the role of that expert knowledge and particular ethics knowledge has played into public policy in the pandemic, and the role that it can play going forward. This is part of a current research project that I'm leading with Professor Federica Angela at the University of York, in which we evaluate the role of expert knowledge in informing public policies in the pandemic. We are a case study lead for Italy, but it's a comparative project with the UK, the US, and other 16 countries. Okay, so I would say that there are two main differences between the first and the second wave of the coronavirus pandemic. The first is that we now have much more evidence about the mechanism underpinning the spread, morbidity, and lethality of SARS-CoV-2. The second is that the scientific consensus around lockdown measures, which characterized the first wave, has been visibly breaking apart. This is vividly illustrated by the debate between the Great Barrington Declaration on the one hand and the John Snow Memorandum on the other hand. The Great Barrington Declaration takes a stance against blanket lockdown measures and proposes to focus policies and resources towards focused protection of the most vulnerable. They talk about the older demographics, but also other vulnerable population. And here I would like to refer back to what Halima was saying. How we define vulnerability is key, and I think it's important for the discussion. There are different layers of vulnerability, and it is both biological, socioeconomical, mental health layers, and we do have to find a way to operationalize these different layers in policy. And we should not leave that only to scientists, because they're not scientific question only. Anyhow, the Great Barrington Declaration has been met with strong criticism by the signatories of the John Snow Memorandum, who highlight how a focused protection of the most vulnerable is not practicable option, and the uncontrolled spread of the virus would lead to an excessive burden on healthcare system and an unacceptable, and they write unethical, death toll. And the John Snow Memorandum signatory argues in favor of blanket lockdown measures. So this current debate in the second wave presents a conundrum for policymakers and politicians. which of the two memorandum should they follow when they say they are following the science? While following the science might have been a palatable option in the first wave of the pandemic for policymakers, when there was a scientific consensus supporting lockdown policy, this has evidently ceased to be a feasible option as scientists have taken opposite views. We argue that this following the science ditto was happening at least partially because scientists were stepping in where politicians left a decisional void by retreating behind the thin wallpaper of value-free science. Now, value-laden conflicting views about both problem definition and solution are typical of policy wicked problems, a construct developed by Alford and Head in 2017, and that increasingly applies to the COVID-19 global crisis, in which multiple urgent interdependent social goals exist, which generate a fundamental problem of prioritization. While disagreements that arise among scientists are often thought to be merely empirical or methodological, this is not the case in the context of the pandemic and this second wave. As a matter of fact, wicked problems, which are normally associated with policy choices, have now trickled down and permeated the scientific community and the very process of translation of evidence into policy advice. So we argue that the current approach aimed at trying to ascertain who is right and who is wrong, for example, campaigning for colleagues, members of the public to sign up for a view, Gray Barrington or Jon Snow, is not particularly helpful. On the contrary, it may lead to the perception that scientists are hiding something from the public, omitting some important information, acting paternalistically or in bad faith, or a combination of this, as highlighted by the literature around epistemic descent in scientific knowledge, the Melo Martin and others. And when this happens, we know from literature in other contexts that this leads to confusion, disengagement with public health policy, leading to hesitancy, non-compliance, mistrust, so topic of trust again, in expert knowledge and in government. And we see all these phenomena, we have investigated them in other public health contexts, for example, vaccination. So we would like to put forward the idea that the current polarization of views, Jon Snow and Gray Barrington, can be explained on the basis of different weights associated by scientists to three key value aspects of the ethical compass, resulting in different trade-off points. What are these underlying values? Well, at least three, which we like to point out, that according to a pluralistic approach to public health policy, these are the three main values embedded in public health: utility, liberty, and equity. So moving towards the conclusion, if we read the two declarations through the lens of these three key concepts of public health policy, we can more easily explain the current polarization of views. The Gray Barrington prioritize values of liberty and equity, but more to discuss about equity, as it views the wide imposition of restrictive measures as violating individual freedom in a way that is unfair to less vulnerable individuals defined in a certain way. And so less vulnerable should be free to go and continue with their lives. The signatory of the Jon Snow are instead more concerned with utility, the reduction of COVID-19 induced mortality and morbidity, and might also define vulnerability in a different way. Through their different graduate value-based lens, scientists read empirical data differently. So what should we do? Well, we think in dealing with a highly complex situation, it's important to understand how values and hence societal goals are formulated and understood. The starting point for any COVID-19 ethically justifiable public health policy should therefore be the clear acknowledgement of the values which underline the policy, and this discussion should endeavor to reflect on the societal trade-offs of lockdown policies and other public health policies within a pluralistic framework, which is context-dependent and dynamic. On this basis, expert groups, scientific expert group, ethics expert group in general, can offer a range of possible ethically justified policies. However, ideally, it remains up to the politician to to decide which policy approach is best suited to the local socio-economic, socio-cultural, and socio-political context, because politicians need to remain responsible and accountable for choosing which path to adopt in a way that is transparent and context dependent.
Thank you. I'd like to move on to our fourth speaker today. Katharine Littler is Senior Policy Advisor at, sorry, you're shaking your head.
I know what you're going to say, but it's no, I'm the co-leader of the Global Health Ethics team at WHO.
That's super. Thank you very, very much. Katharine is going to speak about the global position and other reflections on outreach. Please do.
Thank you very much, Sean, and apologies for interrupting you there. A great pleasure to be here. I just want to say that I'm going to also do what Bobbie and other colleagues have done and give you personal reflections. These are very much my own reflections and not the position of the WHO. I'm also going to look at it from a slightly different lens, as Sean said, the global lens, but also I think focus on some of the procedural issues we need to tackle in getting ethics into policy making in terms of preparedness and response for COVID and beyond. Because I think if we don't think about the mechanisms that we need to set up in order to be able to translate ethics into policy making, we're never going to win the battle of having ethics embedded at policy making early in the system and not down the end of the system when people start panicking and looking for values or looking for outs or looking for reasons why they're making the decisions they're making. So that's part of it. I think the second bit of why I'm focusing on the procedural and less on the substantive, and I thank my colleagues for doing that much better than I would have been able to do it, is also because I think it's critical that we think how to build a cohort of ethicists who are at the front line of advising policymakers. And I think that's a slightly different challenge to is translating academic bioethics into policymaking. And I think Nuffield's probably very well placed to consider that. I'm only going to make 3 or 4 points. The first one is I would argue that whether we realize it or not, that ethics is front and center of this pandemic and everything that we've had to do. From resource allocation, first with PPE in the clinics, through to now vaccines and how we're going to handle that, through to restrictive measures. These all have ethical underpinnings, particularly at the global language, at the global level, the language that started at the outset of this pandemic, and also some of the language we've been talking about so far today. Issues about solidarity, about trust, about equity. These are ethical in nature. Whether they are being used by political leaders in an ethical manner, I think is another question and something we should ask ourselves, how we can feed into that dialogue going forward. So that's the first place. I think first point, ethics really is at the forefront of this pandemic. How we have fed into it is sort of the second bit of the picture. Then I would also argue that this, other than this pandemic being clearly different to past public health emergencies because it is in global in nature, I would also argue that it's different for bioethics. I think we have had a seat at the table from the out. And I think that may be very different to past outbreaks. So, for example, my experience WHO, the R&D blueprint, which really has set the agenda for research and development in terms of the pandemic from WHO and beyond, convened the first meeting in early February. And the ethics working group was one of the 9 working groups established. So it's been there since day one. It's had a footing, it's had a seat in the table, it's been on the discussions, it was there on the agenda. The scientists, whether they wanted to listen to it or not, were forced to listen to it because we're in those plenary sessions. And I think that's a really important detail to point out. We have a seat at the table. Questions about effectiveness and whether we're being listened to is stage 2, but I think that's really different. On the back of that, as I said, we at WHO established 2 working groups. One was this ethics working group, which has 19 members from around the globe. So it's global in nature, but 19 members of a global group, that's not every voice. I'm going to own up to that, but at least it is more representative. And I think we're hearing more voices than we used to hear. So I think that's really important. The other one that we have is now focusing on the ACT Accelerator. I'm sure most people are aware of that, but that's the initiative that was set up by government, non-profit organizations, funders, WHO and other UN agencies, really to accelerate and as much as possible translate into equitable distribution, vaccines, therapeutics, and diagnostics. And once again, we have an ethics group that's advising on ethics and governance. So it's front and center of decision making. And I think that's really important to acknowledge there is a seat at the table. My third point that I'd like to make is I think there are really interesting models for feeding ethics into the decision-making process. No one size fits all. So I've given you our models at WHO, and they are the working group model. We had a webinar where we discussed different national models and how ethicists are feeding into national policy-making decision. It was really interesting. We had a Florencia Luna from Argentina talking about the commission that they'd set up there, and that was ethicists, but some of the difficulties with that. We had Maxwell Smith from Canada talking about they had a provincial model of ethicists feeding into the provincial decision making. And then finally, I think the third person on that was Elena Bux, who's the chairperson of the German National Ethics Committee. And she made a really interesting point. Like, I think she said, first and foremost, she had been invited into a lot of conversations because she was in the media. So really interesting conversations about ethicists having a presence. But she was saying she was often the lone wolf. She was often by herself in a lot of these advisory discussions. She was the only ethicist at the table. And I think that is great that there's an ethicist at the table, but it also presents problems because it is the only view. And you have to carry the conversation, and sometimes it's hard to be listened to. So I think there's really interesting questions about considering the model we need for ethics, feeding ethics into the policy making. That leads me on to my near final, my penultimate point, and that is the challenges, I think, coming out. So one I've already alluded to, not everyone has a seat at the table. And how do we change that? How do we get more bioethicists advising more seats at the table? We were chasing our tail in the first phase of the outbreak. I think, how do you decide which topics to focus on? You have limited resources. What are the major ethic topics? Vulnerability, resource allocation. There are research issues. We had human challenge studies. We had lots, really difficult to choose the topics. And how do we get more people around the table to help us choose what bioethicists should be feeding into the policymaking cycle? A belief, I think, by some policymakers that ethics is the panacea. We'd give them all the answers. They'd be able to fall back on us in terms of tell us what to do. Whereas I think it's the values and the frameworks that we can help guide policymakers. So really focusing on that. I think I would like to point out that I think the ethics community was better prepared than some other communities for this outbreak. We have a lot of guidance. Whether that guidance has translated into decision-making is a question that we need to ask ourselves. So I think we need to look at the models going forward in terms of preparedness of what we could advocate for. I think Nuffield is in a really interesting place as what some people call the de facto National Ethics Committee in the UK, to think of what kind of support it could give to the ethics community to translate decisions into policy and ethics into decision-making. And finally, the preparedness, I think, has been at the forefront of my mind for a long time. Just prior to the outbreak being announced, we had set up this public health emergency preparedness ethics network. It's got a FEPRIN as the acronym, sounds like some sort of dosage of a drug you would take. So I might need to rethink that, but really to think about these issues. And I think what's really struck me, and the FEPRIN, the idea about FEPRIN is to build capacity globally so you can get contextual ethics advice. That would be the other thing. You know, we need to make sure our ethics advice isn't dominated by the same voices. We're allowing other people a seat at the table. And then the final point, outreach is critical. How do we reach the communities we need to be speaking to? We can't just be talking to ourselves. So, and what does that need to look like for bioethics? I think we have to have outreach with scientists. We have to have outreach with policymakers. They need to understand our language. and we need to translate our language into policy language. And I'll finish there. Thank you.
Thank you very much. You very, very helpfully summarised some of the themes that are running throughout those 4 presentations with your tripartite statement of trust, equality and solidarity. As we've all seen, there's been various degrees of emphasis on the lessons that we can learn from the doorstep, from other nations, from disparate power relations and disparate vulnerabilities, and the need to build expertise.